What's cooler than being cool? Joining us on Cool, 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 the podcast that explores intersections of exciting technology, fascinating people, captivating stories, or a combination of all three. We're going to help you embrace your inner cool kid today as we go behind the scenes with today's innovators and storytellers, and we have someone who's an incredible storyteller as a guest today. I'm your host, Cameron Kitt. I'm the founder and CEO of Yo-Yo's, a documentary storytelling company. And today we have the privilege of chatting with Katie Beaudoin, the awesome researcher and a professor at High Point University, critical care PA, and head of advanced practice Pulse. Katie, thanks for coming on.
Hey, thank you so much for having me today. I'm really excited to be here.
I'm so excited to have you. I want to talk about, how medicine is changing and how we treat people. And you have a really important story of your own personal experience that really changed that. So I want to lead with that. You talked about an experience you had, a big conversation that we've had is just how do you maintain humanity and remembering that people are human? Can you tell me that personal story that really changed things for you?
Yeah, absolutely. I've been practicing in medicine for nearly 20 years. I can't believe it. And it's interesting how the universe kind of brings us to special moments in our life or special circumstances. And one of these actually it involved my mom in a car accident. And, what are the chances that I happen to be in fellowship trained in emergency medicine and trauma and then neurosurgery, critical care? I felt like my bedside manner was good. I feel like I'm a compassionate, empathetic provider, but this really was a game changer for me being on the other side of medicine. And of all places, I was in Indianapolis and I received a phone call. And by the way, I live in Texas. So for me to be in Indianapolis during this time was just, it was a fluke of the universe. And received that phone call from a nice bystander. Hey, your mom's being life flighted. What? I mean, talk about a heart-stopping moment. Actually, at first it started, your mom's been in an accident. She's asking for you. Okay, it must not be that bad. Mm-hmm. Tell me what the car looks like, because that'll tell me if I need to panic or not. And she was like, what car? That's when my heart dropped. Then she's being life flighted, right? So those moments where you just can't prepare. I've done code blues. I've done emergency situations my entire career. Nothing prepares you for that. And we go, I call my best friend. She's actually an ER doctor. We go down to the, level 1 trauma center. It's busy. Unfortunately, it's one of those multi-casualty accidents. There's 11 people there. It's chaotic. It's also July. And this is where they were med students yesterday, doctors today, interns. You've got all sorts of new kind of graduates who are bridging into their clinical year. And, having done trauma surgery, I went in right away and I kind of recognized some red flags hit by 80 miles per hour, things that they didn't do in terms of the type of scans. But the numbers on the screen looked really good. And she had this kind of distracting hip injury, a big femur fracture. And, but right away I asked some questions because I know too much, right? And I'm like, oh, there's a paraspinal fracture on her back, basically like this point in your back between your scapula. It's one of the hardest places in your entire body to fracture because that's the core around your heart and your chest and where our rib cage is. Everything's built to protect that area. A fracture there means a lot of impact. And I just said, have you scanned her? Long story short, she was stable until she was not, but she was downgraded. And at first she said, I have chest pain, and so of course it's shift change. The nurse, somebody comes in with the EKG machine and I just stopped. I was like, get out. At that point I had realized she's in shock. I redid her blood pressure. Blood pressure is down to 50, heart rate's 50. It never went up. In my mind, that's neurogenic shock or God knows what else. And so kind of sprung into action. And throughout that entire hospitalization, I would see things that were missed or wrong, or it could have been catastrophic. Mm-hmm. And it just, it really struck me, the nurses who would come in and look at me as a family member. So not only from a care standpoint, somebody just to pause and go, are you okay? That would bring me to tears. Recognize that I haven't left in 3 days, hey, I got this. Why don't you take a break? Or the physicians who would actually take the time to answer my questions, the care providers and that whole continuum. of being on the other side. It was hard. It was all this control that I had none of. And so it really made me a more thoughtful provider. I tend to take probably too much time talking to people, but it brings back the whole, focus of medicine, following that Hippocratic oath and being compassionate providers. But there's no compassion grading scale. There's no way to measure that, right? So
maybe someone will try to invent an AI compassion rating scale based on your eye dilation and your heart rate,
or the inflection in your voice, right? Yeah. Are you speeding through it? Are you doing this? And I think with all the hiccups I saw, there were points in there that were just human nature, and I think that there's so many evolving components to medicine that are super cool and are going to make it better. But I also think there's plenty of components in medicine that we need to have to fear about. Like, we're all going to have jobs, and we still need that human interaction. And there's some really, really neat different areas of medicine that are actually going to get more individualized with patient care, because of the pharmacogenomics that we're focusing on. We're looking at precision medicine, and we're actually able to tailor medicine now to an actually genetic sequence in people. So, I could really transition to over all the benefits. With access to care, how lucky am I that my mom was in a big city and had this level 1 trauma center.
Well, and that someone called you and knew to call you, and all these things that lined up. So I just want to come back to that story.
Sure.
What would have happened if you weren't there?
She might have died. She got downgraded to a room that had no monitoring, had no central monitoring. It was a room with a monitor. It wasn't centralized. Nobody was sitting there watching it because they thought she was stable enough.
Mm-hmm. That's scary.
That's really scary.
But, like you said, there's a lot of good things, but I think what I'm hearing from people who are on the forefront of changing medicine for the better and miss more, patient-centered, human-centered care is really coming back to more of the way things used to be done, right? So improve it using technology to give back. Like you said, you think you spend too much time talking to patients. That's really struck me. How could it be possible that you could spend too much time talking to patients? In fact, it would be ideal if you want to talk to me more. And my only experience of doctors is that I always feel like I'm keeping them from something important every moment that I'm in front of them, right? That somehow I that I need to rush to get it out. And hopefully, I sometimes have thought I got to prepare my little speech so that they get everything. And, this idea of just being able to spend time. So
I hate that for people because, yes, a great deal of time is spent, because of production pressures. Preventative care is preferable to cure, right? And so really the people that are focusing on prevention are only allotted 10 minutes per patient on a schedule. Yeah. And then spending hours after work or not capturing all the details of that conversation. The average person, I was listening to a talk by Abraham Varghese. He's an incredible physician. The average person gets interrupted by their provider 14 seconds into talking. And Sir William Osler said, if you listen to your patients carefully, they will give you the diagnosis. But we have to have the time to listen and actually touch our patients. And I think insert AI, and I think that term is used a little loosely. So we're not talking generative, but there's so many ways that artificial intelligence and technology can come in and produce our records. It's not perfect, but it's going to get nothing but better. It can make things more efficient. I think that if we can settle, there's a lot of issues with lawmaking and HIPAA and all that, but the internal servers, it's really complex. Because I sit there and I'm like, why are the nurses writing down each vital sign? Why isn't this automatically going in? Why aren't we having continuous glucose monitoring up in the cloud? Just sending the glucose up in the cloud.
Data problem, right?
Yes. It's a huge data problem. And I hope that this gets solved because I think that it will leave the nurses to give better care because they're not frustrated with computer input, right? Think about access to care. If we can utilize wearable tech to help people, we still have to give people ownership of their own health, but we can help them afford their wearable tech, this can be uploaded, and virtual visits are doable. And also virtual visits for people who don't need to be around other people. If you are immunocompromised, you've got a health problem, or maybe you don't have bus money, or the bus broke down and you can't make your appointment. Maybe you're a busy, I don't know, you're a business person who's flying all over the place. It's really hard to try to schedule a well person's visit in between all your meetings and things like that. So telemedicine is a huge help in access to care. And that is going to be something I think that we can utilize in many areas and improve on that in the future. We just need more providers to be able to utilize it.
It's the right mindset, right? Like the population health mindset, that instead of just saying like, what cool shiny thing can I use to make that, it's not I think so. Have you been, at the end of the day, have you ever been sitting there typing in notes into an EMR thinking, oh my gosh, what did they say? I wish I could remember that. Or did you ever have situations like that where you didn't have the data you needed? Can you tell me a story about that? It
does. Yeah. We're human, right? If you've fallen behind and you're, okay, I'll do that note later. And then you sit there and go, oh my gosh. I like to put personal quotes for my patients, or even a physical exam finding. And I'm sure that happens, that people just go, what did they come in for? We talked about 10 things, but I don't remember what their chief complaint was. And having AI will take away those sort of brain farts, which are perfectly normal when your production pressure has you seeing 20 to 40 people a day.
Yeah. So I'm here. Thank you for pinpointing places where technology can help us be more human-centered. I want to come back to advanced practice because I don't think it's something a lot of listeners might know. Can you give me a quick and dirty definition of what's advanced practice mean?
Sure. Advanced practice providers, it's sort of become a more mainstream term for non-physicians, but it does sometimes involve physicians. So because there are doctors that come from other countries who aren't necessarily American boarded physicians. So they might also be known as an advanced practice provider. For the most part in the US, we are physician assistants or physician associates or nurse practitioners. And both models were designed to enhance patient access to care. We're not a replacement for a doctor, but much of what we do, we are very capable of handling and with the diagnosis, treatment plans, patient education. And then, of course, we work in the same sandbox as physicians and especially PAs. So we're actually trained in the medical model, and we were designed. Really, the idea was to help bridge the gap of primary care physicians. And so they kind of created the PA program, the surgical techs from World War II, surgical field guys, put them through kind of a fast track med school and get them out there seeing people because there was just such a lack of access to care. And so with the deficit, I think there's a massive shortage of physicians with this baby boomer population aging out and retiring. And so the solution really is to have this network of APPs, but we have to be able to work. And one thing that's a hot topic right now is interstate medical licensing compacts.
Yes.
Huge discussion. And there are litigators out there, physician litigators, physician lobbyists, that actually a minority. Like the AMA will put out they have got a group of physicians who are really trying to block independent practice or decrease state agreements on our ability to practice. However, that's when you talk to most physicians, that's really a minority of activists that are trying to keep that population from getting licensed. The interstate compact, all it does, it's not saying free reign for everyone. It makes it easier for us to get a state license. Because right now, say North and South, we don't have the same flu season. So my hospital might have a massive influx of flu right now. It's hot out, but we're all in the air conditioning. So it's being spread like wildfire, or it's cold. You could say it's cold up north, and so it's being spread. And then here, when it's hot out, everyone stays inside. So our flu seasons are different. Well, if I'm having to board people, ICU patients in the ER, data shows that that is not good for people. Nobody does well when they're in the ICU sitting in the ER. It's not proper. It's not the proper place that they should be in the ICU. Sometimes there's a problem with just having providers to see the patients. So if we can get somebody, hey, you're licensed in Texas, we have an agreement in New York, we could use some extra help. I could be up there tomorrow and have all the credentialing and background checks because the states share that. It's also economically more feasible. So it's a way to help people get access to care. And if you have a license in multiple states, that also allows us to obtain positions with telehealth. So I could be seeing somebody in multiple states through my company virtually, including, one of the biggest areas where there was a recent massive study that, and it was on VA patients, but it showed that there's a potential link between the access to telehealth and decreased suicide rates in these VA patients. And it was a robust study. And of course, it's not causation, but some correlation suggesting that alongside in-person visits, we could affect a major change in the suicide rates in our vets. And I think that's translatable to the rest of the population.
Woo!
Huge.
That's big words. And I think you're absolutely right? Preventative care,
yes.
That also flies in the face, right? We're a sick care model, right?
It's horrible.
Generally.
Yeah. We
reactive.
100% are. Mm-hmm. Yes. And that's, again, prevention is preferable to cure. And I see people on the sickest end, and it didn't take me long in my critical care world to go, oh, this is avoidable. If we just had prevention, if this person, I see these things happen where people are failed by the system, and then they end up having that massive blood clot to the lung. It was too little, too late.
I mean, you've seen things I can't really ever imagine seeing. I'm sure eventually you learn to compartmentalize trauma, gore, fearful, scary things. But you've also, Kate, you've just had an incredible career, and you're like nowhere near midway. Like, you went ER trauma fellowships, you're like doctoral trained clinician, you worked in all these different clinics and areas, you started a nonprofit, right? I mean, you're very mission driven. You're not just showing up to kind of clock in. My question for you would be, what advice do you have for others who are looking to start something from scratch in the healthcare space and make a difference?
Don't think, do. Be a doer, not a talker. We are so full of talent and ideas, and you can execute those. If you see a gap in care, you don't have to have a ton of money to act on it. When my roommate and I, she was, poor medical resident, I was just out in my career, we saw this gap of people needing equipment, just durable walkers, wheelchairs, things like that. And it was keeping them in the hospital because they couldn't afford these necessary things to go home with, keep them from falling. Or they're coming in and they fell because Medicare won't pay for a new wheelchair, and they've grown and they now have bed sores, or, things like that. So we saw this need and sort of created this green organization where we were like, figured out with talking to people, there's a lot of people who don't know what to do with the equipment when their parents die or loved one passes away. And so we just started reaching out to churches and other things. And then all of a sudden it grew, and we had volunteers from like wheelchair technicians who were able to really help people. And even at one point, case managers were calling me, hey, low key, can you get me a walker so I can get this patient out of the hospital? Because that was the one thing holding them up, because they couldn't afford a $35 or $55 walker. But I oversimplify it a little bit, but it really isn't hard to find people with shared interests and using your network. And with the internet, it's really easy to find resources and to figure out how do I build a nonprofit. Ask ChatGPT-4. That's actually a great brainstorming resource to go, hey, I see this need. How can I help it? And you can start leveraging your expertise. Amazing amount of networking can be done through social media. And and make it happen. There's grants, there's funding all the time. Just looking on the NIH website, and there's a lot of money out there, even with private companies. So I want to do a study here that looks at continuous glucose monitoring and look at some effects within hospital systems. So
it's amazing.
It's just you just do.
Just do it. I love that. Just do it. Don't overthink it. Just start. And the hardest thing is to just start generally. That must have been so rewarding to see how it grew.
Seeing the people that were helped through it, helping find this super complex standing wheelchair so that a patient could just he could stand and look at his family in the eyes, right? It's helping people find their new normal and seeing the difference it made and in what we think are small steps. But it's really amazing when you do give back, the difference that you really, really can make. Yeah,
it's addictive when you stop making it all about you, right? But I mean, it's somebody who goes into healthcare generally goes into it because they want to make a difference in other people's lives and they want to help people. It's not for the faint of heart. But just thinking about where we talked about the roles that technology can play, I think you have a really interesting perspective that's very different from most of the people I talk to. I either talk to surgeons or medical marketers, right? It's like one of those two people, and you're coming from representing a whole different perspective on how we could treat people differently. And I think that this movement towards advanced practice I'm biased, I'll be honest. I think it's definitely what we need. We have a huge drought in primary care, right? And there's not enough of it giving. But when we talk about AI, I mean, I talked to Rishi Sarab from who's formerly from GE Health. I think now it works at Philips. He was talking like at the end of the day when he visits hospitals, it's like just the admin burden. Like they're not ready to talk about diagnosis. They're like, he was like, I'm seeing nurses walk around with USB sticks. And, I think there's a big difference between what the public has an image of and what is the reality. Can you tell me a story about the difference between the public perception and reality, especially on the hospital level and the care level? Yeah.
On so many levels. I think I was actually discussing this with one of my colleagues the other night. I was like, we especially in the ICU, the ERs, we really protect the general population from what we see in the hospital and what we see, sometimes errors that we see, or not even an error, just maybe it's a staff shortage. And so if you had more staff or better technology, maybe you could have prevented somebody from having respiratory distress. Maybe not. Counterfactualism is a slippery slope. But, when we go to a code blue, maybe that bedside nurse, had she not been so inundated with trying to keep up with her vital sign input, a simple input that should just be automatically put into the system, maybe she would have noticed the change, but more, or might have been obvious, or if there was an alarm that said, hey, in 30 minutes, if there's this many millimeters of mercury, the blood pressure changes, it'll send an alarm to just give you that audible cue, right? There's so many tasky things that we do that could be mainstreamed if we trusted our technology, if we made it more cost efficient. And that is, I feel like there's a lot of legalities and there's the actual whole data storage issue with all of that. So I know it's more complex than I can even imagine. But if I had so many of those little things taken away and actually focusing on the little things and asking the whys, having time to ask the whys, the 5 whys, why is this happening? What could we do to prevent it? And I think that there could be an improvement. And there are some benefits, though, with taking the people out. So think about radiology.
Mm-hmm.
It's been showing that using AI to detect abnormalities in radiology. There's only so many radiologists who can read films, and I say this tongue in cheek, and I don't mean to offend anybody, but I'm like, if you have to wait for the radiologist to call you from his like third lake house to tell you that there's a dropped lung, that patient's already dead. Like by the time they call me, I'm already putting a chest tube in, right?
So
because
true.
I've already picked up on it. And
Yep.
in AI, if that, AI could be a solution where it's automatically detecting those and maybe even triaging those images. If they have 20 stat reads in their box, how are they going to know what's the most super stat of them all, right? Which one do we prioritize? But if there's, think about how fast, AI could read that and go, oh, there's no lung markings. Put this in the red flag box and have him,
Exactly.
him or her read this first. Or
just there. I mean, it's just there to be a first line sorter. I mean, in a lot of ways, AI is being implemented in radiology. It's actually one of my favorite examples in healthcare because it's the one that's having direct relationship with patients.
Yes.
There are women whose breast cancer was caught at stage 1, in part helped thanks to AI, really just machine learning. And it turns out some of the machine learning platforms and what are those called? Like the algorithms were actually trained from NASA data that would do deep space scanning. I thought that was the coolest thing I've ever heard because it was like at the end of the day, if you look at deep space data and breast tissue super close up, they're very similar. It's just like fields of dots. And I was like, wow. But I talked to a former radiologist and he's a friend of mine and I'm going to call him out. His name is Van. He no longer is a radiologist and he was the first voice I've heard to be the alternate. Everyone's always like, oh my gosh, yes. And he was like, yeah, but it's a lot of work and it can add more time and it can add more potential non-cancerous lumps and that can do. And I wanted to just be like, like, it's like, this is just what happens. Like, I get it. It's a change. And I know that sometimes people can feel threatened by it, but that's what you're talking about. Is like, there's no need to feel threatened by a tool. And I just spoke at the AI summit and people are saying like, oh, what's going to happen to film? I don't know what the crystal ball is, but I do know that when the TV came out, people thought that like no one would ever go to the opera or plays ever again. And when photography was mainstream, people thought painting would be irrelevant. I personally just don't think that there's ever going to be complete replacement for what humans do. I think tools are great. Like, yes, I know that there will be some big changes and I know it will be scary, but I don't think human doctors will ever be fully replaced, right? And clinicians. Go ahead.
It's a gestalt, right? Like, and we're humans, we're active. And if you've ever played with Midjourney to make a picture, you know that like you have to think about it like it's an alien that has come to Earth who has no context to anything, right? And so you literally, that's where prompt engineering comes in. And I'd rather AI mark a bunch of overreads on an image than miss somebody's early detected breast cancer, right? And it might take me a little longer to look through it. But I'm the human and go, nope, that's normal. Ooh, you know what? That's a good call. Let's recheck it. And we do this with our trainees too, right? They're kind of our screening tool. If you think about it, they go in and see patients before us, and then they are a blank slate. So they come out with some amazing things, and then we have to kind of train them or go, okay, let's go. Let's talk about this.
Close or good. Yeah. Quick ad break. This podcast is brought to you by Yo-Yos. You Own Your Own Stories, a documentary storytelling company that demystifies cutting-edge technology and human stories with emotional, memorable tales. If you got a cool story to share, we'll help you get it out there. Okay, Katie, speaking of the future, let's make a bet. This is one of my favorite questions. What do you think is the most outlandish prediction you have for the future of medicine? What's something that like nobody else agrees with you on?
Wow, that's an interesting question. Outlandish? Well, it's probably no secret that government-run healthcare is a mess. And I really feel like providers need to take back our field. We are very lucky in the US and, we're in a wonderful country, and our healthcare really, other people from other countries will look at us like we're insane for complaining about a thing. So we're still very lucky, but we can do better. We can do so much better in the form of healthcare costs.
Yep.
In getting education out there, getting people to trust providers again. making healthcare accessible, but also making people accountable for their own health.
Yeah. I mean, one thing I notice when I travel, of course, would you say like a place like Brazil or France is government run healthcare, right? That's like our NIH. Okay. Well, in countries where there's like a bigger benefit for the population to be healthy, the food tastes different. Things like they want people to be active. I've definitely liked the idea of let's be accountable for our own health and be more proactive. And I think there is a growing movement and interest in that and more education. But can you give me an example of how providers being in charge on something very specific would make my healthcare experience different as a patient?
Well, those healthcare providers who only provide, there are some out there that only provide based on guidelines. The guidelines from the CDC who say, actually recently, Endocrine Society said, don't screen vitamin D. Well, we have an obesity, don't screen for X, right? Like, we don't need to check it, but that's not taking into account that most Americans are at risk for deficiency and depression and obesity, and it affects bone health and so many other things. And so by just making a blanket statement, don't just screen this because you want to, most physicians and most providers are going to disagree because it's an important screening tool. But because that was put out by an organization, now your payers are not going to pay for that. And so if you give somebody the choice, like, hey, it's going to be an extra $50 to check this lab, I think it's important, they're not maybe going to appreciate that, and they might not have $50. And so that's just one example of a blanket statement. I think there's general guidances that are important for protection of, but there's a lot of blanket statements that are just not individualized.
I can tell when it's not individualized. Right?
100%.
I mean, sometimes you're right. I think it is also important to step back, and I do talk trash a lot about the system. And it's super easy to do that from a place of privilege of having grown up in the US and been party. It's like very important to spend a lot of time in gratitude first and be like, I'm grateful for this system. Mm-hmm. Now, how can I help make the system better? Mm-hmm. Instead of just talking trash, which is easier, right? It's just easier.
Yeah. I mean, and there's a lot of countries, there's people that you have to pay up front or you don't get care. I had a patient that came off literally from a green card lottery, had a seizure. This patient was very sick, and they were from a country where I felt like, I was like, wait, I know of a nurse that speaks that dialect from that country. Yes, we're winning today. And then I go get her, and she's like, oh, whoa, you're speaking up like way sub dialect. So we have no way to translate. But this person just kept saying, I'm doing an LP. I'm sticking a needle into her spine to get fluid. And she's just going, thank you, thank you, thank you. And I was like, why is she thanking me? Like, I feel terrible. And the cousin was there to help translate and goes, she'd be dead. Like, if she didn't give you money right now, she wouldn't have gotten through the ER. She wouldn't have gotten the medicine. She wouldn't have even gotten the medicine during her seizure to stop the seizure. And as we know, if you can't stop seizures, you die. So that's just an example of a very, very far edge, but it's not unheard of even in Middle America, Mexico, that if you want some higher levels of care, you're paying first. And how many people can just pay out of pocket for an emergent $10,000 surgery?
Actually, Dr. Beaudoin, I did not know seizures uncontrolled and unstopped would lead to death. So I'm sorry, that was
Sorry.
I didn't know that. That's a whole side tangent. So you can just seize to death?
Yes.
From what happens? Do you eventually have a stroke?
It's uncontrolled electricity firing, and it can lead to coma, brain swelling,
brain death. Okay, cool. So it just shorts your brain out like a computer. Okay.
I guess that's an easy way to describe it. Mm-hmm.
Wow. Yeah, I'd be thankful too. Let's not forget how lucky we are. I think I talk a lot about what's broken, and we don't talk enough about what works and what's good. And that's why I like focusing on patients' real life lived experience stories. Like, sure. I was making a film about a woman with sickle cell. It's one of my most successful short films. going into it like, oh my gosh, all the things that are bad, right? My documentary brain. And I said, Mariah, what do you want to center in the story? And she's like, Black joy, the fact that I'm living a good, happy life, the fact that I have a daughter, the fact that I have a fiance and all this support and all the good things I get to do. And I had to really check myself and say, oh, I'm so glad she said that. I totally would have not told the story that way. Right? That like, hey, here's the things that you can do. Here's what I'm doing. Like, do it. Like, be an advocate for yourself. Right? I mean, people who have rare disease often become advocates for themselves in a way that we've never thought we had to. But this is just such an amazing conversation. My last question, or my last couple questions, Katie, as we wrap up. What's most exciting for you right now?
All the things. I will comment on your last comment about needing to focus on the good. I think that's just the researcher in me wants to look at both sides. But there is a power of optimism in grit. Okay, so people who are advocates and people, there's a study at in Penn that showed they studied people on obstacle courses and they measured intellect, physical strength, and then just a grit. There's actually a grit scale. And the people with the grit did the best. They had the best performance. It shouldn't be surprising. But I love that point. And so I think that one exciting thing is that people like you, like me, that have grit, we're persevering, we're of change mindset, growth mindset. We have so many areas where we can affect change. And there's literally a niche for everyone to have that moment of gratitude and say, I could do more, I could do better. Even if it's just, I have a friend she's an advocate and doesn't know it. She has Mondays off, and so she goes and does Meals on Wheels. And every now and then one of her disabled patients will go, do you think you could take me to my colonoscopy? And she's, oh, okay. Yeah, okay. Just because it gives that person some reassurance because they're by themselves and they have got somebody in the waiting room. A safe ride. So it doesn't have to be an over-the-top gesture. It could be, instead of food wasting, I'm going to see if my neighbors want some food. Or I don't know. I just think there's so much to be excited about. The field of patient advocacy is really something that a lot of people are focusing on because we want people to be able to help themselves, not just in special diseases, but everyone should have the ability with today's day and age and with the technology we have to have a voice and to speak out when they know something's wrong with their body and be heard and not pushed aside. And that will save lives. And
to be heard and not pushed aside, and that will save lives. Absolutely.
And it can be done in a kind way. It doesn't have to be a rant. It doesn't have to be, it doesn't have to be a dramatic, ugly way, but knowledge is power. And if you have a concise list of everything, you just hand it to your provider, they're going to be like, whoa, wow, okay, I hear you now, instead of coming in and being like, I don't know what my medication is.
Oh, yeah, that's okay. I've been both patients. I've been like, when was day of your last period? I have no idea. Help me. And I've also been, here's my like log of every time I've had this symptom over the past 2 weeks. And having the diary was it was funny. Like that, amazing. Those 2 times I've done that, my clinician was like instantly like looked at me like I was for the first time, like I was a human. And they were like, oh, you did, you helped. Like, I don't know. I just remember that experience of being like, oh, I was thinking in a way that would help them. Like, here's my symptoms. Because once you put pen to paper, anyway. But
it's a gift.
I was on the phone with someone else with a rare blood disorder or myasthenia gravis. And I don't know if it's rare. Yeah. And she was telling the story about, so people with rare disease again, but she was telling a story about like, she knew what therapy worked best for her. She had a crisis. She had to go and there was a doctor who wanted to put her on a certain therapy that she knew wouldn't work for her, that she had tried for months, and he refused to do it. And she was like, right to the point of being intubated and almost dead, and had to like work so hard just to get the doctor to like, from the very first time was like, actually, no, I need this therapy. I need Plex, or I need this thing. Yeah. And it breaks my heart, right? We hear a lot of those stories. So it's like, sometimes like, Katie, what do you do? Dr. Katie, what do you do in that situation when you're telling your physician you need this thing and they won't believe you.
I've done it with my mom to advocate for her. I'm like, hey, she needs to be scanned. Don't just say it's a UTI because she can't actually feel. He's ready. She's the way she talks. She knows enough to love you, Mom, but she knows enough to hurt herself sometimes. Oh, I'm getting spasm, and I think it's get UTIs frequently. Okay, I'm hearing you. Easy enough. And I'm going, no. She has a resistant bug that she got in the hospital, and so she doesn't need that average antibiotic. And so also. The bowel and bladder stuff comes together, and I really think like she never actually gets a fever because you have to just think outside of the box. Not everyone gets a reactive white count. Not everyone gets a fever. But if they're telling you they're drained or they feel bad, you got to listen, you got to start looking. And I think training our younger, I shouldn't say younger, that's ageist, our newer providers, newer practitioners, newer providers to really hear their people. I will, and I'm not humble bragging. Because I had the privilege of being in neurosurgery, I had this lady with Parkinson's, and everyone kind of overlooked her home med regimen. Those people need to be within 30 minutes of their next pill. They couldn't extubate, but what I noticed, I was like, well, what's her home regimen? Well, her son brings in his computer, and it was so complex. Nobody had used her exact regimen at her doses at her times. She had the tube out like a day later, and she had, they hear Parkinson's and they just go, oh, this must be end of life. And he was like, well, she was drinking a Mai Tai last week. I was like, wait, what? All I did was ask what her baseline was. He's like, well, she's drinking a Mai Tai. I was like, wait. We're going to trade. Hold on. Let's rethink this. Let's go backwards.
That small piece of information completely changed the care plan.
Asking the questions. You can't just assume somebody's demented because they're forgetful when they come in. They might live independently and be fine, but they've got a UTI that needs to be diagnosed. And it's making them cuckoo for Cocoa Puffs. Antibiotics, they're fixed. So it's the nuances of medicine. And I think we get that through actually shadowing and just with time too, but also taking pause instead of being rattled and having the pressure of production to take pause when you see something that's not right. And having family members it's very helpful.
Amazing. Well, my last question for you is who do you think would be a phenomenal guest for our show?
Oh my gosh. Dr. Abraham Verghese is amazing. But I have a colleague who is really, she is at Penn. She is their director of innovation. Ooh. And she's a PA who's phenomenal. And she is our president-elect of our national PAEA. That's the Physician Assistant Education Association.
Yep.
And she really has a lot to lean in on the world of education. And she is really savvy with AI and all different levels of integrating that as educators particularly, but in all different areas of medicine as well.
PAEA. Have you guys thought of saying paella? And then you could have paella. Anyway, that's dumb, but it's, at least more memorable.
Pia. Yeah.
Pia. Thank you so much, Dr. Katie Beaudoin. I just want to say thanks for listening to all of our listeners and for Cool. I'm Cameron Kitt, host of Yo-Yos. And a huge thanks to Dr. Katie Beaudoin for joining us and sharing your incredible story. You can check out the show notes to find Dr. Katie's LinkedIn and our website. And of course, if there's another link you want us to throw in there, we will throw it in there as well. And you can always post about what you think about this episode by adding the hashtag #CoolPodcast. Dr. Katie, thanks for coming on.
Hey, thanks for having me.